In the past few months, it's been brought to my attention through discussions with Dr. Trevor Lyons of Ottawa, Canada, and reading several research papers that perhaps periodontal health cannot always be achieved with good diet, good home care, and good restorative or periodontal care. And the reason why this is not possible is there may be a etiological agent involved in the development of periodontal disease, which is a oral parasite. It's called Entamoeba Gingivalis. And to give a bit of background on this concept and to relate his experiences over the past couple of years, I've asked Dr. Lyons to speak to us about some of his original experiences in treating periodontal disease in regard to Entamoeba gingivalis. Dr. Lyons?
Well, up until the end of about 1977, I firmly believed that the principles of good home care and good dentistry were quite sufficient to control periodontal disease, and quite sufficient to control caries as well. And it had been in the hands of myself and my patients in my practice up until that point very effective in controlling caries. And towards the end of 1977, I began noticing an increasing number of patients who seemed to be developing a periodontal deterioration. And in February of 1977, one of my patients, a 35-year-old woman, presented complaining that her upper right central was moving and that her gums felt itchy. She had very good oral hygiene, and she had no subgingival calculus, and I was at a loss to understand exactly what was happening in this particular case. So I did the usual things which the average dentist I think would do under the circumstances. I re-instructed her in her oral hygiene regime and chided her gently for not having been working hard enough at it, and I ran a curette around the margin of the upper right one. Although there was no calculus or anything else there that was an irritant, I felt that this would be of some benefit, and followed this in the usual things that one does for a periodontally involved tooth. About 2 weeks later she was back in. The condition around the upper right central was now a lot worse. The pocket depth had increased from 2.5 to 5 millimeters. The tooth was still mobile and still moving labially, and I smeared her plaque and examined it using a phase contrast microscope. Now, I've been examining plaque routinely with a phase contrast microscope since 1971, and my technique had always been to take it from the mesial of the lower left 6, because I felt that this was going to give a statistically significant comparison patient to patient. Well, at this point in time I decided to diverge from my usual technique, and I smeared the plaque around the upper right central, and I found within her plaque a large number of protozoan parasites, which were later identified as Trichomonas tenax and Entamoeba gingivalis. At this point in time I believed that protozoan parasites were non-pathogenic and had no causation in any kind of periodontal disease or disease in the mouth. But both myself and the patient were somewhat concerned, so the decision was taken to eliminate the parasites before embarking upon further extensive periodontal care. At the end of her first course of treatment to eliminate parasites, we had successfully eliminated parasites, and to everybody's surprise and pleasure, we'd also eliminated the periodontal defects. The tooth was no longer mobile, it was no longer drifting, and pocket depth had returned to 0.5 to 1 millimeter around the upper right central. Subsequent to that, we used grassline to bring the tooth back into its proper position in the arch, adjusted the occlusion so that the lower teeth weren't banging it out labially again, and it's remained stable from that time to this, which is a period of just over 2 years. This sort of set me on a path of looking for oral parasites, which I hadn't necessarily been doing before. I'd just been examining plaque, and I had noticed some oral parasites in some people's plaque, and I just disregarded them because they were supposed not to cause disease. All the patients who had oral parasites discovered in their plaque went on to a periodontal deterioration. So I now changed my technique and started examining plaque from the worst area of the mouth. And what I found was that patients with periodontal deterioration, which was generally speaking pockets in excess of 3 millimeters, a generalized mauvish discoloration of the tissue which was flaccid and had lost its tone and contour and stippling and bled easily, and very often they had a halitosis that was faintly reminiscent of garlic. These patients, all from these periodontally involved pockets, gave parasites, usually Entamoeba Gingivalis. Less than 10% of the parasites that we found were Trichomonas tenax. So during this period of time, which was the following winter now, we're getting into 1978, what I did was to treat patients with parasites for the parasites, and sat back and noted with a great deal of pleasure from both myself and my patients that periodontal deterioration disappeared and that their tissues returned to a normal healthy color, tightly bound down, no longer bleeding, and the halitosis disappeared, and the tissue resembled that one would expect to find in the mouth of a child.
Now, Dr. Lyons, since this concept runs contrary to accepted periodontal therapy, at least in North America, I'd like to ask you if there's any other people doing work or research in this general area throughout the world.
The answer to that is yes, and perhaps if I give you a very brief historical background, I can tell you at the same time how we found out some of this information. When I first started finding oral parasites, I turned to people whom I considered might be experts, and finally I was directed to Dr. Ted Schulten of the Ontario Ministry of Health's Parasitological Service. And it was thanks to the hard work of Joe Palmer and Dr. Schulten that we made positive identification of the type of oral parasites that I was finding, and also developed a test kit and a simple way for any dentist to take plaque and send it in to any laboratory so that a plaque search can be made for oral parasites by a laboratory using staining techniques which would either augment or supplement or be instead of having a chairside microscope. As a result of the number of cases that I began to turn up showing 100% correlation between periodontal disease and the presence of parasites, Dr. Schulten conducted a search and review of the literature, and in the process of that we found cases reported, for example by Brumpf as early as 1913, where they had found 100% correlation between oral parasites and periodontal disease, and many other researchers at the beginning of the century had similar results. They called it pyorrhea alveolaris at that time, which I think is probably still a very good term because it dispenses with a lot of the latter day definitions of what kind of periodontal disease we have. And one thing that I have found running constantly through all types of periodontal disease, whether it's periodontitis simplex or periodontitis complex or periodontosis, is that oral parasites were always present. The type of parasite sometimes varied, the type of destruction seldom varied, but the amount and type of inflammation varied according to whether or not there was a bacterial superinfection or supra-infection which was superimposed over the parasite infection, and whether or not there were any occlusal interferences which would alter the pattern of bone loss. As a result of the literature review, we finally came up with a very definitive article which had been published in the Journal of the American Dental Association in August of 1929, and it had been published by some American protozoological researchers. Charles Kofoid was the chief of these, working out of Berkeley, California. And they had 100% correlation between periodontal disease and the presence of oral parasites, and had further gone on to experimentally induce periodontal disease in experimental animals which initially were free of both periodontal disease and oral parasites, and they did this simply by infecting them with oral parasites. So the situation really became very, very clear just at the time of the Great Wall Street crash and immediately prior to the Depression.
What was the problem at that time, Dr. Lyons, that they didn't pursue this line of treatment?
Well, At that time they didn't have any drugs that were suitable for the treatment of the disease. The only things which they had used had been derivatives of ipecac, which they had got some success with, and emetine hydrochloride. The problem with emetine hydrochloride is it's a very dangerous drug and had a tendency to cause fatalities. Of course, in the Depression it was much more important to hang on to your patients than to get rid of periodontal disease. So that method of treatment, which was medication approach to periodontal disease, largely fell by the wayside pending the development of new drugs. These new drugs were developed during the Second World War and basically fell into a range of anti-protozoan drugs. Malaria, of course, is caused also by a protozoan parasite. And by 1962, one drug in particular, which was metronidazole, had been developed, it was on the market, and it was found very effective in the treatment of certain kinds of oral infection. It's also been used for vaginal trichomoniasis, also used for intestinal infections, particularly giardiasis and amoebiasis.
Could you tell me a little bit about the protozoan parasite group and a little bit about the drug metronidazole?
Well, starting with protozoans, protozoans is a group of one-celled animals, and they can be roughly subdivided into those which are free-living and those which are host-dwelling, in other words, parasites. Now, some of the free-living protozoans are also opportunistic parasites, that is to say, they will live in a host if they find that the environment is suitable. The main groupings of the animals according to their morphology is the ciliates, and in the free-living ciliates we find paramecium, and in the parasitic ciliates we find Balantidium coli. There are no ciliates that live in the mouth. In the flagellates, we might consider, for example, Euglena as one of the free-living flagellates. Giardia Lamblia would be one of the parasitic flagellates, and this one lives, as does Balantidium coli, in the gut. And in the mouth, a flagellate is Trichomonas tenax. Of the amoebae, the soil amoebae, of course, are free-living amoebae, although they may be occasionally opportunistic parasites. Entamoeba histolytica is probably the best known parasitic protozoan of the amoeba group, and it of course lives in the gut and causes dysentery. Entamoeba gingivalis is its first cousin. It lives in the mouth, and we believe now, or at least I believe, that it is the cause of severely destructive periodontal disease. Now, of course, there are many other protozoans which parasitize the human race. We have, for example, the malarial parasites, Toxoplasma, Entamoeba coli, Entamoeba hartmanni, Dientamoeba fragilis, Endolimax nana, Chylomastix, Mesnali, and on and on. Now, some of these are pathogenic. Some of them, their role is unknown, or else it's being re-evaluated, and some of them are already suspected of being pathogenic. An example of one of the protozoans whose role as pathogen has recently been re-evaluated is Giardia Lamblia. It was once thought of as being commensal, and it's now considered sufficiently pathogenic and sufficiently serious that it has become a reportable disease.
This has nothing to do with dentistry, but it just shows that protozoan parasites, generally speaking, are being re-evaluated in their role in disease.
Trichomonas tenax
are very loosely similar in appearance to perhaps Euglena. They're very small. They're less than the size of a leukocyte. They're usually about the size of a rather elongated erythrocyte, and they're very difficult to find in a phase contrast examination. They're also very difficult to find with any of the staining techniques that we have done so far. We really don't have a good test for these yet, but they only form about 8% of the infections that have been noted more recently, particularly in Russia. In Kiev, for example, they have thousands of cases of patients with oral parasites and periodontal disease treated with metronidazole to eliminate the parasites and successfully eliminating the periodontal disease. But I digress. And now we come on to the situation with Entamoeba gingivalis. Entamoeba gingivalis is an amoeba. It looks morphologically almost identical to Entamoeba histolytica, and in fact it takes an expert to tell them apart. And the differences are very slight, and they are purely in the construction of the nucleus. The type of movement that they have is identical. Both amoebae will move around on a slide very, very rapidly in a slug-like motion, looking for all the world like a slug as they extend themselves in a long elongated body, sliding across the slide. And both of them, in my opinion at least, are pathogenic. Entamoeba histolytica burrows into the gut wall. You get a node of parasites grouped together.
It is assumed they secrete exotoxins which
are presumably what is responsible for a breakdown in the connective tissue and epithelium, and an ulcer is formed with typically described as overhanging edges, and then it becomes secondarily infected by bacteria. Entamoeba gingivalis, on the other hand, will be found in the mouth, and when we take plaque and we look at it, we find them typically, if there's an area of plaque with parasites in it, they'll all be grouped together. In other areas of the plaque there won't be any parasites, so the same kind of node formation seems to occur.
So this is a common effect of the two parasites, Entamoeba gingivalis and Entamoeba histolytica, that they both seem to cluster together or group and have a focal point.
Yeah, I think this would be a pretty apt way of describing it.
When they're clustered together, we assume that exotoxins are being secreted, and of course this concentration of parasites will lead to an increased concentration of this toxic material, which will have a much more profound effect because of its concentration.
And then you get tissue breakdown. So in the gut we get an ulceration of the gut wall, and in periodontal disease we get an ulceration of the gingivae where it is resting against the neck of the tooth, so that we have this sort of band-like collar of ulcerated tissue. And then from the evidence which we have been able to elicit so far, it's highly suggestive that Entamoeba gingivalis then invade the tissue. We have recovered them from pus, from apical abscesses. We've recovered them within granulation tissue from an apical granuloma. We've recovered them from pus, from tonsils, and other researchers, as well as recovering them from periodontal pockets, have also recovered them from tonsillar pus and also from bronchial secretions. And when the parasites get into the upper respiratory and lower respiratory tract, they can set up infections which in some cases can be extremely severe.
And of course, Entamoeba histolytica does not seem to be able to cause an infection in a bacterially sterile intestine.
So it's possible then that Entamoeba gingivalis relates to a host of diseases, one of which seems to be periodontal disease in terms of attacking the tissue aggressively around the tooth itself in a pocket that's more than 2 or 3 millimeters deep. Can you tell me a little bit about the criteria for getting established around the tooth?
Yeah, let me answer that question by giving you a sort of a typical outline of what might happen to the average patient. The average patient would be possibly in their mid-20s to early 30s. Their oral hygiene would be relatively good, but for one reason or another they would have had a certain amount of neglect in their mouth. There'd be a certain amount of inflammation due to bacteria in the plaque at the gingival margin, and as a result of that, if they catch or contact the parasite, then the environment within their mouth is conducive to the survival of the parasite. At that point, the very small parasites cannot survive without motile bacteria, because the small parasite feeds on motile bacteria, such as, for example, the lactobacilli, which one finds in plaque so frequently. The next phase of the disease from there is basically there'll be a slight increase in pocket depth, there'll be very little sign of inflammation, there really wouldn't be any cause to be alarmed about the patient's general periodontal condition, and there's no disturbance, in other words, of either their general or their dental health. Phase 2 of the disease is they'll go into a series of flu-like symptoms, which will be protracted or repetitive. So they'll have something like the flu, or a cough, or a cold, or sore throat, with the usual symptoms which go along with that: headache, itchy eyes, runny nose, fatigue, and sometimes they'll complain of either bleeding gums or halitosis. The important point is that regardless of what kind of periodontal disease it is, the one common denominator is the presence of all parasites in destructive periodontal lesions. And since recent research has showed a wide variety of different bacteria in different periodontal disease, with no one strain common to all kinds of periodontal disease, the important point is that the common denominator is not bacterial but protozoan parasite.
Now, if you take myself as an average 33-year-old dentist, what are the chances of myself having contracted or come in contact with the Entamoeba gingivalis?
Well, I think the chances are very high. Any dentist who's been in practice for 2 or 3 years will have had his fair share of aerosol mists kicked up by high-speed instruments, and within these aerosol mists there almost certainly will have been oral parasites, so they may have contracted the disease within the first few years of practice. But the rate of progress of the disease beyond the first stage will be slowed down tremendously by good oral hygiene and by good dental care. So the end of the first phase of the disease is that the patient will slowly go into a diminished state of health, where they're not as energetic, they're more fatigued, they're going to bed earlier, they get more frequent headaches, but they slowly acclimatize to their diminished state of health. Stage 2 of the disease. This is basically periodontal disease, and they will run the full range of a periodontal deterioration. And I'm sure we've all seen patients, some with subgingival calculus, some with none, some with good oral hygiene, some with poor oral hygiene, some with an occlusal problem superimposed over this, and some with none. And this will give us our basic definitions. So, to reclassify periodontal disease, I would suggest that periodontitis simplex is an infection with oral parasites with a superimposed infection of bacteria, giving the inflammation, and no occlusal stress. Periodontitis complex is the same condition, but with occlusal lateral stress thrown in, and periodontosis, which is that non-inflammatory deterioration of the periodontium, would be all parasites with little or no bacteria. And those are the classifications of disease which I understood, and those are my clinical observations of plaque as it relates to those conditions.
What would be the final stage, or stage 3 then, Dr. Lyons?
Well, stage 3 of the disease is an overlapping stage, and what we have is the complete periodontal breakdown. We have abscessing occurring, excessive mobility, migration of teeth either falling out or being removed. And at the same time that this is happening, there seems to be, common with periodontal patients, much more serious disturbances of their general health, which were not present before they developed periodontal disease and seem to follow in sequence down from there. In the past, we've tended to regard these as an indication of creeping senility, and these would include hypothyroidism, diabetes mellitus, various arthritic changes, cardiovascular disease possibly,
and perhaps some central nervous system disorders.
Fine, so then you see the infestation of the digestive tract by Entamoeba gingivalis as a progressive lifetime battle between the host and the parasite.
Yeah, we have to limit the digestive tract there to being basically the mouth and pharynx, because after the pharynx, Entamoeba gingivalis will be found basically in the respiratory system. And from the appearance of Entamoeba gingivalis as a multinucleated giant cell, I am becoming increasingly suspicious that many of those serious pathologic disorders wherein multinucleated giant cells are present. What we may be looking at is not multinucleated giant cells, but a section through an Entamoeba gingivalis where the section has missed the nucleus of the amoeba, but has gone through all the nuclei of its ingested food, because Entamoeba gingivalis ingests as its primary food source leukocytes. So that when you see a section through Entamoeba gingivalis, it seems to have a lot of human nuclei in it, and it does. But this is partly digested food and not a human cell with many nuclei. So yes, a lifetime battle with, unfortunately, the patient usually on the losing end of it,
because Entamoeba gingivalis does not seem to engender any marked antibody response.
And as a result of that, we just do not seem to have any basic defenses against the disease. So it's a disease that we can contract and get treated for, and recontract and get treated for. And the unfortunate thing is that many of the things which patients do to try to eliminate periodontal disease, and many of the things which I was taught to do to eliminate periodontal disease, by disturbing the tissues, actually spread the disease deeper and further. And what one needs to do with a parasite infection is the least amount of instrumentation coupled with the maximum amount of medication until the disease is eliminated, and then most of the instrumentation becomes unnecessary.
Tell me a little bit what has to be done to prove this a pathogen, and tell me a little bit about the type of study that should be done or conducted to evaluate on a broad scientific basis the pathogenicity of Entamoeba gingivalis and periodontal disease and other associated upper respiratory tract illnesses.
First of all, the original observations which were done from 1913 to 1929, and the experimentation which was done from 1926 to 1929, was pretty conclusive that Entamoeba gingivalis is pathogenic. The point has been proved. In order to reinforce the point, I have treated approximately 700 patients now with oral parasites and periodontal disease. Some of these were reinfections, so we have got confirmatory slides now in over 500 cases where patients had periodontal disease and parasites, and subsequently when they were treated for their parasites, the periodontal disease just healed up and went away. So that was very nice. What does one need to do further from there? Really what we need is anything from 50 to 150,000 case reports. Unfortunately, I can't do that by myself.
100,000 case reports, roughly.
I think that 1,000 dentists across North America should be able to have Entamoeba gingivalis investigated on a clinical study basis. It would only take 75 cases per dentist, and we'd have a very conclusive argument.
To put it very simply, Dr. Lyons, could you just tell us how we diagnose in clinical dentistry the parasite Entamoeba gingivalis?
That's a very good question, Paul. What needs to be done now is that laboratories and their technicians across the country have to be trained in how to process dental plaque, how to stain it, how to read the slides that they get so that they can recognize Entamoeba gingivalis, and dentists have to learn or be trained in the use of a phase contrast microscope and the recognition of Entamoeba gingivalis in a wet mount. Then we'll be getting somewhere. Right now, nobody's trained to do it.
I'll tell you what I do with a typical patient. Typical patient comes in and they get a very brief clinical examination. We check oral hygiene, gingival condition, the amount of plaque, the pocket depths, the amount of inflammation, whether or not they have halitosis, and if they have a submandibular lymphadeninitis. An eighth point, which is sometimes recorded, is whether their salivary production is normal, because low salivary production is very often diagnostic. Then plaque is taken from the deepest periodontal pockets. Now, before plaque can be taken, the patient must be instructed not to brush or floss for preferably 24 hours, but certainly not less than 12 hours beforehand. Having done that, one then needs a special fixative, and it's an SAF fixative kit. The SAF is sodium acetate, acetic acid, and formalin, and this fixative was developed by Dr. Schulten. The importance about SAF is its low toxicity, it's non-damaging to dental instruments, it has an indefinite shelf life, and once the parasites are placed in it, they are preserved indefinitely until they can be processed in the lab. It does not need refrigeration. Other fixatives are more hazardous and less effective. So, taking plaque then from the deepest periodontal pocket, I use a number 6 straight-ended probe, and it's moved around from the mesiolingual to the mesial. The plaque is lifted out and immediately deposited into the fixative, and the instrument agitated rapidly to detach the plaque. I'll take plaque from all 4 quadrants of the mouth, from the worst areas, and then the container is tightly resealed, and when the form is filled out, it must be marked dental plaque. Otherwise, arriving at the lab, it might be mistaken for an empty container and simply thrown away.
If one is fortunate enough to have a phase contrast microscope, and in my opinion all dental offices should have a phase contrast microscope and personnel adept at using it,
then the situation becomes somewhat easier. What one needs to do is to take a drop of the patient's own saliva, and I stress the patient's own saliva, not sterile broth, not artificial saliva, not normal saline. These fluids will not provide reliable results. We must have homeogenic liquid which will not cause any distortion of the parasites. Then again, take a drop of the saliva, put it on a slide, take plaque from the deepest periodontal pocket and from the base of it, deposit it down on the slide, into the saliva that is, drop on a cover slip, and then press that cover slip down really firmly in order to squash the plaque out into the thinnest possible film. I use a doubled over pipe cleaner, and I press really hard, and sometimes if I've got too much saliva or too much plaque, it'll come oozing out from the edges of the cover slip, and I just wipe it off. And then I make my low power search. Now, when I do my low power search, instead of using the phase contrast condenser, which is matched to the low power phase contrast objective lens, I use the condenser, which is actually matched to the high power phase contrast objective. So on my microscope, I have 100 times low power and 1000 times high power, and that addition of one additional zero from 100 to 1000 times is important. It could be from 125 to 1250, but it must be a 10 times factor. Then you can use the high power phase contrast condenser with both the low power and the high power objective lenses. Then under low power, using that setup, you'll get an apparent dark field illumination, which makes the entamoeba easy to see, and under high power you'll get a bright field phase contrast, which will make the positive identification possible. The protoplasm is clear and non-granular. The movement is typically amoeboid. Sometimes they'll be sluggish, just putting out a pseudopodium in one direction and retracting it, and other times they'll be moving rapidly across the slide. Occasionally they'll be dormant, just sitting there, non-moving. There'll be a number of inclusions within the endoplasm which are round and look like nuclei, and they are the nuclei of leukocytes. And then the identifying factor is the Entamoeba nucleus. The Entamoeba nucleus is smaller than an erythrocyte. It's about 4 microns across to my recollection. It has an outer chromatin ring on which one can sometimes see the thickening of the 3 or 4 chromosomes. It has a central karyosome so that the whole thing looks like a bicycle rim with a hub, and the hub is sometimes a dark spot, and sometimes it's another second very small circle inside this outer circle, and sometimes one can see strands of chromatin material which join the outer ring to the central karyosome, and it's the identification of the nucleus of the parasite which is diagnostic.
Now, how are we going to treat this disease if the phase contrast microscope survey is positive, or if the report says, yes, we found oral parasites in your plaque specimen?
Well, here we just take a leaf out of the book of the gastroenterologists and the gynecologists, and parasite infections of both of these body cavities are treated in basically the same way. The organism is considered to have invaded the wall of the body lumen and also to be present in the lumen itself. So if one gives medication which is entirely parenteral, the systemic medication will eliminate the parasites from within the tissue, but will not affect the parasites within the lumen. And if one uses a local antiseptic, it will eliminate parasites within the lumen, but not within the tissues. So we need to use both. And I have used, with most success, metronidazole and a metronidazole-based paste. The unfortunate thing about the paste is the taste. Sorry about the alliteration. So the regime of treatment that we follow is metronidazole times 30, and to minimize side effects of medication, the following should be employed. On the first evening, with food, 1 metronidazole. On the second day, again, 1 with breakfast and 1 with the evening meal. Now, the reason for building up the dosage slowly to the 3rd day, which is the full dosage, which is 1 of these 250 milligram pills every 8 hours, is that as the parasites are destroyed by the medication, the disintegrating parasites seem to release a lot of antigenic material which can cause quite a severe systemic reaction for the patient. And we try to minimize these side effects. It's important for the patient to realize that most of their side effects are due to the destruction and disintegration of the parasites.
And we're fortunate with Entamoeba Gingivalis that the release of antigenic material during treatment does not cause as severe a reaction as occurs with some of the treatment regimes for some of the other parasites. Patients should be instructed that if they do become very ill, they should cease medication. They should also be instructed that they should phone in if they get any side effects. There are 2 side effects which we commonly see due to the medication alone. One is a slight and transient headache, and the other one is an altered sense of taste. These both disappear when medication is discontinued. One drug interaction which must be avoided is metronidazole and alcoholic beverages. They interact very badly. Your patients won't die if they take them both at the same time, but they'll sure wish that they could.
Could you outline for us your treatment approaches now for a very bad periodontal condition, and perhaps describe a case history that you've done, and then we'll talk a little later on about a mild case.
Sure. I think before I do that, I'd better finish mentioning the paste that we use. What we have taken is 1 ounce of metronidazole vaginal cream. Then we take 6 mexiform tablets, which is an intestinal antiseptic and also antiparasitic, and both drugs are antibacterial. The mexiform tablets are finely crushed and mixed in with the paste in order to stiffen it up. And due to the extreme bitter taste of the paste, we've disguised the taste by using a very strong anise flavoring. The patient will still have a bitter aftertaste, but at least it's tolerable. The paste is applied to the gingival margin with a toothbrush finger, pipe cleaner, but preferably with a toothbrush, on all aspects, buccal, lingual, at least twice a day. This is done at the same time that the medication is being taken.
When the paste is applied, it should only be applied very sparingly, and the excess can be spat out, and then the patient does not eat or drink or rinse, of course, for the next 55 minutes. But the important thing is, if too much paste is used, it can be very nauseating, the patient salivates excessively, and all the good which you're trying to do is undone. So, we come on to severe cases. That's how we treat a severe case, and we sit back and we wait and we see how many of the pockets heal and at what depth they remain. After approximately 6 weeks, and during the 6 weeks, they will have continued with the paste, and they will also have been using adjunctively modified Torrance powder, which is basically 6 parts baking soda to 1 part salt. Again, it has to be finely ground, and an ordinary household blender will do this very nicely. And the patient takes about a teaspoonful of this and just pats it onto the gingival margin with a saliva wetted finger. This ideally should be done once a day. Patients on a salt-free diet should use baking soda by itself. The effect of the powder will help to keep the teeth looking white, help to keep the numbers of bacteria down, and help the tissue to respond normally, and also will act as a partial preventive, because when oral parasites come in contact with the powder, they're destroyed by reverse osmosis. What do we do now if we've treated the patient and they're back in and it's 6 or 8 weeks later and they still have some deep pockets? Well, the first thing we do is check again for parasites. If there's parasites, they'll then go back onto medication, and before they finish the medication, they come back in and they have any subgingival calculus carefully removed. When I remove calculus, I use very fine curettes, and I always dip the instrument into the metronidazole mexiform paste prior to each movement with the scaler or curette. This will minimize the chances of any post-operative infection and soreness, and at the end of the appointment I'll carefully apply a little of the metronidazole mexiform paste in all the interdental areas to give us a sterile wound which will then heal. Now, having done all those things, one will still sometimes find that there's a very deep periodontal pocket, distal on a 5, mesial on a 6, a trifurcation involvement, something like that, and it still won't heal. Take a 5cc syringe with a 20 or 18 gauge needle, blunt the needle, bend it through about 110 degrees, and then fill it with metronidazole mexiform paste. Instruct the patient in how to inject the paste to the depth of the periodontal pocket, slowly moving the syringe out as they fill the pocket. They should do this for a period of time until the pocket is healed, and they should do this at least twice a day and continue during this period of time in using the paste. Sometimes during this period of time the patient will recontract the disease. The disease is contagious. It's spread by mouth-to-mouth contact, which can be direct, which needs no explanation, and indirect, which can include any object which goes into the patient's mouth which may have been contaminated with somebody else's saliva. My last patient this morning actually just returned from a cross-country skiing trip in the Rockies, and he'd been treated the second time around for a reinfection in January. He was clear by the middle of January. In March or April he goes off to the Rockies, he gets some spring skiing in, everybody's passing food and water bottles and so on and so forth around, and in spite of the precautions which he'd endeavoured to take, he knew he had the disease back again. Within 5 days of this he noticed his gums were getting sore and bleeding. He got back to Ottawa. He came down with a protracted and lengthy flu-like illness. He was pronounced not to have mononucleosis. It was, as with many other of the case reports I have, labelled as a, quote, virus, and that he would just have to sweat it through and ultimately it would go away. When we found he had the protozoan parasite, of course, we prescribed, and I'm quite confident that as soon as he starts his medication, the remains of his flu-like symptoms and his extreme tiredness, which he's still experiencing, and his frequent headaches, which he's still experiencing since March, will all suddenly go.
This has been the pattern that has repeated itself with patient after patient after patient.
Yeah, I have another interesting case. A young lady, she's 27 or so. She'd had severe facial pain due to an occlusal problem. The slide which she had been eliminated. The balancing side interferences had been eliminated. She was balanced in centric. She was balanced in lateral excursion. She's back in now. She has severe facial pain, and it seems to be centered around the center of masseter, in other words, approximately where the parotid is, and it's going right up into her head and back into the occipital region and down her neck and even down her left arm. Her ECG was negative. Her plaque examination was positive for oral parasites. She started medication. No other treatment was done to relieve her pain. Within 2 days, she's free of pain.
You're suggesting that the parotid was infected with the oral parasites. Is this possible?
Yes. Now, I had another interesting case present about a year ago. A patient came in with her husband who'd broken a tooth, and at the end of the appointment I looked at her and said, "What's the matter with you?" And she said, "Well, I have this vague infection in my salivary gland, and I have to go and see the ear, nose and throat surgeon next week, and he says maybe they're going to do a biopsy, and I may have cancer, and it may be an infection, and I'm really worried about it, and I've been really tired, and I'm feeling sick, nauseous that is, and I'm off my food, and I'm losing weight, and I've been really feeling worse and worse over the last 2 years." She had some of the most active amoebae that I have seen. She started treatment that night. The following day, the salivary glands were no longer tender to palpation. The salivary production returned to normal. The salty taste she complained of disappeared. Her energy and her vitality returned, and she said when she'd finished her medication that she felt better than she had in 4 or 5 years.
This was over a period of 10-day course of medication.
This was over a period of 10-day course of medication. Now, they were both young patients. I had a patient sent to me by a periodontist. This lady was 57. She was unable to keep her mouth clean. She said she was brushing 3 to 6 times a day, and still the plaque was forming. She complained her gums were very itchy and sore, and she said, "They're driving me crazy." Clinically, she had 3mm pockets, this generalized mauve deterioration of the tissue. Plaque was triple plus, in spite of the fact that she'd brushed quite recently, and she had amoeba present in her plaque quadruple plus. Post-treatment, she complained of nothing the matter with her mouth. The periodontist said she couldn't believe how good the patient's mouth looked, and of course the pocket depths had returned to 0.5 millimeter and no inflammation, and the tissue looked firm, and it was firm and healthy and pink and stippled and no more symptoms, and she said again that she felt better than she'd felt in many years. Acute ulcerative gingivitis presents in the usual way. Plaque examination reveals fusiformis, spirochetes, Entamoeba Gingivalis, and large numbers of bacilli. One of the interesting clinical observations or microbiological observations has been that when we have given patients locally effective antiamoebics which reduce the viability of the amoeba, we find that spirochetes are able to penetrate the amoeba wall, to get inside the amoeba, to swim around inside the amoeba, and then to exit from the amoeba. So spirochetes would seem to be the natural enemy of amoeba, and far from being a cause of periodontal disease, I think they're possibly our last line of defense. Fusiformis, like the hyena, is a scavenger, and once the amoeba has been effectively destroyed, for example by modified Torrens powder causing the cell membrane to rupture, then Fusiformis will start swimming inside the carcass, scavenging it.
As we know, in any infection, it's generally considered good policy to test the type of bacteria or whatever organism is involved, and then prescribe accordingly. If we have patients with periodontal disease, it is not considered prudent, I would imagine, just to prescribe metronidazole or the adjunctive pastes. How would you caution our listeners on that?
Yeah, I would certainly caution anybody not to go jumping in to every periodontally involved patient with metronidazole and the metronidazole mexiform paste. Make a positive diagnosis of oral parasites first, because then when you're asked about treatment at any point in time, you can say you're treating for oral parasites and you prove that they're there, and there is the adequate documentation. Charles Cofoyd is enough of a documentation, I feel, to be ample justification for the treatment of patients for oral parasites. And then when you treated them for oral parasites and suddenly the periodontal disease is gone and they don't need periodontal surgery and they only need a quarter of the scaling that they previously needed, then you say, well, gee, we don't have to treat you for the periodontal disease after all, because we got rid of the parasites and obviously they caused the disease. Now sometimes if a patient has got a yeast present in their mouth as well, the yeast will overgrow, and clinically the tissues will look almost identical with a yeast infection as they will with parasite infection. So the microscope really becomes all important, and if they have got a yeast infection, prescribing metronidazole and the paste will eliminate all the organisms except the yeast. The yeast will overgrow and you'll make the patient worse. So under those circumstances one needs an effective anti-manilial preparation in order to eliminate that disease. The thing that I have found most is when oral parasites are present, we have an aggressive osteolytic response occurring with an apical migration of the periodontal membrane and all the typical parameters of active, destructive, deteriorating periodontal disease. It can be slowed by home care, slowed by dental care, but generally speaking not arrested. With medication, when we have a positive diagnosis, we can eliminate and cure the disease and get healing, which previously has been thought of as impossible. If there's yeast there, it simply stops healing. It does not progress, but it doesn't get any better either.
Dr. Lyons, I want to ask you again about trifurcation involvements. Perhaps you could just clarify a bit your approach to them and how the patient handles them with these water-soluble creams and products that we've been utilizing to inject in the trifurcation.
Sure. Well, once the pocket depths have returned to normal and all the irritants, tartar, overhanging margins and stuff like that has been removed, if there's a persistent trifurcation involvement, the one important thing is it must be kept clean. And if it's kept clean, then generally speaking there won't be any further deterioration. And my particular pet way of keeping these things clean is to use a pipe cleaner, and during treatment we'll have the patient when they're using the paste, take the pipe cleaner smeared in the paste through there. So they're going to be smearing the gingival margin with the paste, and in trifurcation and bifurcation involvements they'll use the paste through there on a pipe cleaner. And then once they are clear of disease, then the next important thing is prevention. Now the routine way that we've prevented periodontal disease just doesn't work. So what we have done is to develop two reasonably effective preventive aids. One is the modified Torrens powder, previously mentioned, which can be used in perpetuity at least once a day, and it should be used on a finger and not on a brush. It works by reverse osmosis, and by keeping the bacterial population down, it makes the mouth a non-conducive place for the establishment of parasite colonies. The other effective preventive, which requires no patient dexterity, is a mouth rinse, which is basically acroflavine. Acroflavine from 1926 to 1929 was investigated along with the other essential dyes. Acroflavine was found to be the most effective amoebicide and would kill amoeba at dilutions down to 1 in 200,000. We formulated a mouth rinse which is acroflavine 1 in 50,000 in 16% alcohol with an orange flavoring. For alcoholic patients it's set up straight in water. The reason for putting it in 16% alcohol is alcohol, along with all the other barbiturates, narcotics, and particularly the antihistamines, all seem to affect amoeba, making them much less active and motile. They become sluggish and dormant and round up, and they seem to have a much lower rate of metabolism as a result of these drugs. Alcohol having the same effect on them directly when it's taken in the form of, for example, sherry. We know that alcohol will penetrate the plaque. We know that it's a wetting agent. We know that it penetrates, therefore, into the parasite, and by dissolving the acrylflavine in it, we can take this protoplasmic poison straight into the body of the parasite. The important thing about acrylflavine 1 in 50,000 as a preventive used 1 to 3 times daily is that it's non-tissue irritant, and it is not to any great extent bacteriostatic. It has to be stronger than 1 in 33,000 in order to be bacteriostatic. The method with which we have our patients use it is to take 1 teaspoonful of the mouth rinse at full strength, to rinse it round the mouth for 5 minutes, spit out, and then don't eat or drink or rinse for the next 55 minutes. And again with the Torrens powder, pat it onto the gingival margin, spit out all of the excess, and then don't eat or drink or rinse for the next 55 minutes. Other drugs that can be used for the treatment of parasites, apart from metronidazole, tetracycline is weakly antiamoebic. The dosage regime that we employ is 250 milligram capsules twice a day, no milk products at the same time, obviously, and this is continued for 2 weeks. At the end of 2 weeks, we usually re-examine to see if there's parasites in the plaque. If there are parasites in the plaque, or if the patient isn't completely healed, or if it's been a very severe infection, then tetracycline 1 BID for a further 2 months. Another drug which is not yet completely proven, Atabrine, another antimalarial, is effective against most of the intestinal protozoa. We've used it in a couple of cases of resistant infections and found that Atabrine, 1 tablet 3 times a day for 5 days, is more effective than metronidazole over 11 days with the paste. So that Atabrine by itself seems more effective than metronidazole and metronidazole paste.
But Atabrine has unpleasant side effects.
But one of the things that we've tried to do all the way through to get rid of these protozoans is to go into an overkill situation and then to try to prevent reinfection during the convalescent phase, which can last from a matter of weeks up to nearly a year. Anybody who's going to be prescribing any of these things should remember 2 things, I think. One is the importance of a sound medical history and consultation with a physician if necessary, and the second one is to be totally familiar with the drugs that they're prescribing, and a compendium of pharmaceuticals is, to my way of thinking, essential from this point of view.
I'd like to have a little summary then of step-by-step approach to handling a new patient. New patient comes in, obviously a periodontal situation is very active, so the first thing we're going to do is tell the patient a little bit about the concept of parasites and say that we should not prescribe anything without doing a proper testing. Then we either test by utilizing a microscope, phase contrast microscope, to observe the amoeba, or else we take a SAF kit to do a sampling, send it off to the lab. That comes back positive. Now in the meantime, being highly suspicious, we put the patient on a preventive mouth rinse. Tell me a little bit about your choice of rinse here and the progressive treatments, maybe 2 or 3 different things with a mild case or a severe case, just to summarize it one more time.
Okay, well, if we're waiting for results to come back, we put them on modified Torrens powder once a day and a pre-treatment rinse, which they use 4 to 8 times a day. The reason for the fluctuation in time is sometimes they can't keep it in their mouth for 5 minutes, sometimes they have to eat within the 55 minutes. Modified Torrens powder, of course, is the salt and baking soda combination, which has been finely ground up. Some patients like to add flavouring to it, for example cinnamon. The preventive rinse is 1 in 50,000. The pre-treatment rinse is 1 in 10,000. The pharmacist has a bottle of concentrate and just mixes up using alcohol from the liquor store, which is diluted so that it's 16%, and then he adds the flavoring. Once we have got our positive diagnosis, or in the case of a severe infection we've used the pre-treatment rinse to get the numbers of parasites down, we then go ahead and whilst the patient is being treated with the drug and with the paste, we get them to continue with the modified Torrance powder. Sometimes the patient will develop a severe reaction medically, and because of their general symptoms they have to discontinue treatment. Very occasionally the worst complication that we get is what is basically an herpetic stomatitis. If the patient develops an herpetic stomatitis, and we have, I think, 3 cases in 700, so the incidence isn't high. What we do there is we take the patient off all medication, we get them to continue with the rinse frequently, to use modified Torrance powder, 3 teaspoonsful in 4 ounces of hot water, and use that as a rinse, to stop toothbrushing entirely, and to use modified Torrance powder on their finger. Then this, after about 5 days, will subside, by which time the patient will have developed something of a skepticism for the whole treatment, so they need a little bit of hand holding, and then they retake treatment. And when they retake the treatment, surprisingly enough, the herpetic stomatitis does not recur. We've had 1 or 2 problems with urticaria. Generally speaking, the urticarial response ceases immediately medication is discontinued, and this can be controlled with the use of antihistamines. However, antihistamines, because we think that they affect the metabolism of the parasite, will also slow down the rate of uptake of the drug and therefore prolong treatment. In one case with urticaria we suspect that there may be something like Endolimax nana in the patient's system, and this is why he's developing the response, is that when he took the metronidazole,
the other parasite was not as affected by the metronidazole as Entamoeba gingivalis, and therefore this other parasite overgrew.
And he's therefore developed this problem as a side effect of treatment, but not a side effect of the drug.
That summarizes the treatment. After the treatment has been done, what do you follow up?
As far as follow-up is concerned, the most important aspect is home care on the part of the patient, and this involves the usual regime of home care which is effective for that patient, coupled with the specific anti-amoebics that we've previously mentioned, the modified Torrance powder and the Acri 50, that's acroflavine 1 in 50,000 mouth rinse. We have patients in a high-risk category group using the mouth rinse anywhere from 4 to 6 times daily, normally 1 to 3 times daily, and all of them using the modified Torrance powder once daily or as they feel they require it. The medical implications are largely speculative, but they're based upon clinical observations of dental patients where there is a correlation between oral parasites and systemic disease, and a clue as to what other parasites may be related to other diseases, and an indication that this demands much more careful investigation. As far as dentistry is concerned, I really do feel from the research which has gone on in Russia and in France and Germany, Spain and Italy, and in the United States back in the 1920s and the early part of the Depression, that the case has been proven for the pathogenicity of Entamoeba gingivalis, and that many of the diseases that we see in the mouth should really be classified as oral amoebiasis.